Welcome back, everyone, to another virtual shouting session of Hearts for Health. I hope y'all's Thursday is going well. It's almost the beginning of the school year, the beginning of August, so the summer did fly by pretty quick. But today we're joined by Dr. Tan. She's the Director of Clinical Research at the Diabetes and Thyroid Center of Fort Worth. She's also been named one of the top docs at Fort Worth in endocrinology since 2012, so been on a hot streak since then with great practice. I do have a few reminders for y'all, especially if you are new to our program or virtual shouting in general. At the end of each of these sessions, including this one, we'll have a Q&A. So around 7:40 p.m. Central, or if you're on the East Coast, 8:40, just adjust your time. We'll have our Q&A. So with that last 20 minutes, any questions that y'all post in the chat, we'll read out, and Dr. Tan will be able to answer them. My second reminder and my last reminder is that we do have a listserv and an Instagram page if you'd like to follow us for more sessions after this. We have these sessions on Mondays and Thursdays, typically at 7 p.m. Central. Sometimes times do vary, but you can get all that information in terms of specialty, who the speaker is, and what time and day they are on our virtual shadowing page or on our Instagram page or our listserv. If you'd like to subscribe to our listserv, we have a subscription form at the bottom of every page on our webpage or our website. And if you happen to have trouble finding it, we're happy to help you out. If there's any questions that y'all have, feel free to email us. Our email is community@hearts4health.org. That's all the reminders I have for y'all. Like I said, if you have any questions about what I just said, feel free to go ahead and email us. One thing I do want to say, especially for this week, is we do have the deadline for our refugee mentorship program for English literacy coming up. That's a volunteering program where any volunteers can join in as tutors, one-on-one or in small groups, for refugees, immigrants, or non-native English speakers. We have a whole page on that on our website. And again, the program is called SRMI, or the Student Refugee Mentor Initiative. And we also have our mentorship program. The deadline for that is coming up soon. If you would like to be a mentee under the guidance of a medical student, a PA student, a dental student, or a pharmacy student, we have all of those mentors on board, 4 types of pre-health categories. And if you happen to fall into one of them, feel free to submit an application. We're not able to take all applications, but we do accommodate as much as we can with the volume of mentors that we do have. With that said, though, I don't want to take up too much time. Dr. Tan, take it away.
Okay, can you hear me okay?
Perfect.
Okay, very good. Good evening, everybody. Thank you so much for allowing me to kind of present to you all, and thank you very much for the invitation. So I am a clinical and adult endocrinologist, and I wanted to present today my take on being an endocrinologist. I'm going to present a few topics in the science of endocrinology that I love so much. I'll also kind of talk about my journey and what is involved in practicing in the science of endocrinology. So my journey, I graduated from medical school. This year, I celebrate my 25th year of becoming an MD. So I graduated from the University of the Philippines College of Medicine in 1998. So I am an international medical graduate. So after graduating from medicine in 1998, I moved to the United States and I started my residency in internal medicine in New Jersey. So Atlantic Care Regional Medical Center, finished in 2002 and got into endocrinology. Endocrinology was always my first love, even in medical school, and I'll tell you why. And I'm hoping to invite more people into practicing or looking into this specialty. So here are a few pictures. So I practiced in a diverse program. It was a community hospital in the heart of Atlantic City, so that we were very busy, especially during weekends and holidays, because it was close to in the middle of all the casinos. So I realized then that if you lost money, you had a heart attack. If you won money, you had a heart attack. So it was a very, very busy kind of residency, and I loved it. There were a number of foreign medical graduates who practiced or trained with me. So it was a very enjoyable time. After that, I got accepted into the University of Missouri, where I was there for about 2 years. And the fellowship of endocrinology takes about 2, and sometimes there's an optional 3rd year of research. And so what I know at that time, I knew I was too young to know how to fail. So you just keep going, you show up every day and you have courage. And then after a period of time, you finish. And hopefully you find your passion at that time. So I would like to just move the screen around. I would like to kind of get into the root and the meat of my talk. And I want to speak about the science of endocrinology. What is endocrinology? So the Greek word of endocrinology or hormone, the Greek word means to impel, or it's a substance that sets things in motion. So meaning this is the science of different glands in the body that create and secrete substances or chemicals. They're produced by these glands, and when they are spewed out by those glands, they're transported through the bloodstream, meaning there's no connection from here to there, but all these substances and chemicals are poured into the bloodstream and circulate through your entire body. And so how do they get into a very distant organ is that those organs have receptors for them. And so I feel that the gland system is really supporting CAS. It's not like a heartbeat that you can feel or a breath that you take. So when they are in their normal state, usually you don't feel them. When they are dysfunctional, though, they wreak so much havoc and can affect so much. So the types of hormones, there are different categories. Do we want to categorize them
One thing, Dr.
into...
Tan,
Yes.
I don't think the presentation, the right slide is showing up. We still see the starter slide.
Oh, I'm so sorry.
All good.
Oh, there you go. I'm so sorry. You haven't seen. Okay.
All good.
Oh, sorry. Okay. So the types of hormones, we'll just use this then. So types of hormones are categorized into the composition versus where they're secreted from. So for example, in terms of composition, the types of hormones can be lipid derived, meaning there are certain hormones that we have that are, the backbone is cholesterol. So we have cortisol, aldosterone, estrogen, progesterone, and testosterone. They are all composed of a cholesterol backbone. And there are hormones that are amino acid derived. Your epinephrine, norepinephrine, your thyroid hormones are amino acid derived. And then you have peptides, which are larger batches of amino acids, insulin, glucagon, prolactin. So there's so many different types of hormones. And in terms of your body systems, this is a picture of where they all come from. See, it's all over. And so I feel that endocrinology really is the heart of, it's the heart of the body. And it can go from the brain all the way down to the thyroid, the liver, you have your stomach. The gut is a source of 250 plus hormones that we are still discovering at this point. And so therefore they come in all kinds of shapes and sizes and all throughout your body. And when we categorize these hormones into like what stimulates them to produce, there are many stimuli, for example, humoral or changes in our chemical makeup. Believe it or not, even the major electrolytes in the body are controlled by hormone. You have an entire hormone system that regulates your sodium. You have another separate hormone system that regulates your potassium, so on and so forth, calcium, and glucose. And so changes in these, the concentration of these electrolytes stimulate hormonal secretion. And hormones can be stimulated by other hormones because they interact with each other. And then finally, neural, and we know this, our typical stress, the nervous system and our emotions directly stimulate hormone production. So it's really a kind of multiple systems that speak to each other and control each other. So the basic science and the basic drama in the endocrine system is what we call the feedback loop. So I do not want you to be intimidated by this picture. So basically, I'll give you a basic kind of understanding of, let's start with thyroid gland, okay? So the thyroid gland is actually regulated by our pituitary gland that produces TSH, or thyroid stimulating hormone. So, and this is the same relationship for all other hormone systems, where your thyroid or the end organ is the heater, and this is the thermostat. So for example, if the heater produces too much hormone, the pituitary gland will say, oh, I'm feeling too much. I don't need to stimulate you anymore. So therefore, the TSH will be low. If the heater is not producing enough, then hey, I'm not feeling it. I need to crank up some more. So I need to stimulate you by increasing thyroid stimulating hormone. So this is just a feedback system. So when one is too much, the other will drop, and so on. So let's get right into the different systems. So I have a few cases, and I want to give you an idea of what we all deal with as endocrinologists. So first is, and I'm also going to give you updates on where we are in the science of these conditions. So diabetes, many recent advances in diabetes. And so I want you all to realize that insulin is a hormone. Glucose is the chemical that insulin interacts with and recognizes. And so that is the basic kind of relationship between the two. So we have many recent advances in how we check blood sugars and how we manage with insulin. So we have a picture on, I feel that this is the greatest kind of contribution to the science of diabetes management is our continuous glucose monitors. So if you can see, over so many decades, all we had was finger stick glucoses, you know, pricking your finger, putting it in a tester, and then lo and behold, you have a number. And so, but it's very limited. You are limited in terms of, we see it as almost akin to your driving, and you know, you're trying to get somewhere, but you're only opening your eyes 1, 2, 3 times a day, however much you're checking your blood sugars. But we now have instruments that are stuck, you know, you have a sensor that you stick right on the arm or sometimes in the abdominal area, and you're checking, these instruments are censoring or checking your blood sugars every minute. And so to me, and then it spews out that number that goes to your iPhone or your Apple Watch. And what's interesting to me is that because it's checking blood sugar so many times, the important thing is actually the arrow. 2 points make a line, so you get a trend. And so therefore, for example, if you are a diabetic and you're getting ready to eat and you want to check your blood sugar and it is 90. So typically normal before each meal is 80 to 90. What is low sugar is typically 70. Okay, you're close to low, you're 80, you're a very good number. You don't know, is it 80 going up or is it 80 going down? 80 going down makes you more cautious, and 80 going up makes you braver to give you a dose of insulin. So this is so, so helpful. And I feel this has really changed the landscape of diabetes care. Actually, even in the adult world, in the older population, I feel that this technology has helped a lot of older people be more independent and stay at home, have less ER visits, less calls to emergency medical personnel, and actually allows them to live a more independent life instead of being kind of relegated to go to a nursing home. So this is how we look at blood sugar control nowadays. So it used to be, we check your blood and look at this test called an A1C. So A1C is the average blood sugar over the last 3 months. And so, but now what we are looking into, you see that A1C is just an average. So you might get a good average and you are actually under control based on that blood test, but your blood sugars can really be into extremes, either too high or too low. And if you have an average, then that fools everybody, and including you. And so this is how we look at diabetes control nowadays. When the patient comes with their instrument, we download it and we get this report. And so, for example, we have Eric's best glucose day. So this is the report that we get. This is the most important thing to us now. So what is the range that we're talking about? 70 to 180. And so time and range is how we measure how good of a control you're in. What percent of the time in the last 2 weeks are you inside that range? Isn't that much more meaningful, right? And so it also enables us to help you kind of change or look at your patterns and help you make changes to your medications. If this was a patient on insulin, for example, you would see that, hey, the blood sugars are high all the time, or your A1C is 7.5, technically is still not under control. And so therefore, the instinct previously was high A1C, I see some high blood sugars, increase your insulin or increase the medication. But sometimes you have to be careful, and this instrument allows us to see that, hey, wait a minute, is the high reading actually a response to you being low a couple of minutes ago? And so therefore, perhaps it's not a great idea to keep increasing the insulin. So maybe the idea is to kind of reduce the amount of insulin that you're taking. Are you high because you're always responding to low blood sugars? With these instruments, we're able to kind of do better for these patients. So that's another part of that's just another way, another report. And so CGM, there's been studies even that have proven that if a patient with diabetes was given, or we make you wear the continuous glucose monitor, it actually improves your glucose control without me having to tell you to change anything, with me not having to escalate medications. So this is the work actually of the JDRF Foundation. That these are the parents of type 1 diabetes. They have really moved these studies forward. So this is now a very well accepted kind of way to monitor blood sugars. And therefore, we also lose all the judgment of, having patients stick their fingers. So a lot of patients have a lot of baggage behind them. They really hate checking blood sugars. They don't want to tell their doctor that, it hurts. I really don't want to do it. So they are being labeled as bad patients. But now we have technology where we do not have to have that baggage anymore. Let the patient wear these instruments and we get even more data out of it. So I think this is really one of the big advances. And what about insulin pumps? I do not also want you to be intimidated on what insulin pumps are. I tell patients all the time, pumps is just a machine. So a pump allows you to, inside that pump, there's a syringe full of insulin. And so that is just an instrument that allows you to store 1 to 2 or 3 days of insulin's worth. And it is an instrument that allows you to deliver little bits and pieces of insulin 24/7. So there's just an instrument that allows you to store your insulin and to give it to you or inject it to you. You're connected to it 24/7, and it enables you to kind of get little bits and pieces of insulin 24 hours a day. And so the insulin pumps now have also advanced because we have continuous glucose monitors. The pumps that we have, how does it know to deliver this amount of insulin? In the past, we used to have to program it, and we have to tell the pump, okay, for every hour, this patient needs 1 unit of insulin an hour. And then every time a patient would eat, a patient would push a button in the pump saying, I'm eating this many carbohydrates, and therefore, will you give me this amount of insulin? So this is how pumps really work. But nowadays, insulin pump therapy is also advancing because they are now able to talk and interact with the continuous glucose monitor. It is able to receive the blood sugar reading that is in real time. And there are algorithms now that enable the pump to change and adjust according to what the blood sugar is and the direction it's going. So these pumps now protect you from a low, because if it senses that blood sugars are low, it will suspend insulin delivery. And when the blood sugars are on the rising, the pumps are also able, through these algorithms, to give you little bits of what we call microboluses. And so this is where pump therapy is going now. In fact, very recently, this is a very new company. We call it Beta Bionics. So the holy grail is to find a bionic pancreas, right? So an instrument or a machine that is like our own and is able to give us insulin according to how much we need, and also able to take back so we don't get too low. So Beta Bionics is a company, and this is their technology, meaning they're improving. These companies are constantly coming out with new and improved. That currently what we have is Tandem is the more popular, or Medtronic pumps. But these, what they do is they just make it more and more automatic, meaning these new pump, what it is saying is that you don't even have to tell it how much you're eating. So because it's so quick and has an algorithm or AI behind it, it's able to kind of chase your blood sugars as it goes up according to what you've eaten. So you can watch out for the news and when this is rolled out to patients. So in the science of insulin, what if somebody doesn't want to be on a pump? And are there advances in insulin? You bet there is. And we have diabetes medication. I just want to review How does your body do it anyway? Because really, it doesn't need to be complicated, and people don't need to be confused on what these insulins do. So the basic principle is your body needs sugar, right? 24/7. So even if you did not eat, you have a mechanism, meaning your liver stores your blood sugar, and your liver spews the sugar into your bloodstream 24/7. So that even if you didn't eat, you're protected, you're not going to die. The liver stores the sugar for the body, the brain cannot store it. So the liver stores it for the brain, but the liver has to give it somewhere, and the conduit is the blood. So the liver spews out sugar 24/7. And the same way the liver spews out blood sugar, so the sugar is in the blood, insulin needs to recognize it from the pancreas and comes out to tamp it down. So you have a basic yin and yang in the body. The same way you have a basal secretion of blood sugar from the liver, you also have a basal or intrinsic secretion of insulin from your pancreas. And then, so that is what we call our basal secretion of insulin. And that is just there for you in the background 24/7. And when you eat breakfast, that's the second way the body receives carbohydrates or glucose from the food that you eat. So there is another way your body secretes insulin is bolus, meaning in and out to match the food that you eat. So breakfast, lunch, and dinner. So you have two things going on. One is basal and one is bolus. Okay. And so when you have diabetes, the premise is you do not make enough insulin. If you're type 1, you make 0 insulin. If you have type 2, you don't make enough insulin, and because your cells are also resistant to it. And so therefore, if I just told you that this is the way your body's supposed to do it, then I'm supposed to give you insulin that just has to do that. But it's easier said than done, because we have also taken a long, long time to perfect our insulin. And so as you can see, we have inhaled insulin, and this is merely a booking system, if you can see, and this is time in hours. Okay, if you want short-acting insulin, how fast do you want it to go, and how quickly do you want it to dissipate? So that's the science and drama of all of this. We have rapid-acting insulin that is in and out of your system in 4 hours. We used to have the basic insulin molecule is regular insulin, and it used to be fast until there were faster insulins that came out. And so this is now one of the more slow, fast-acting insulins. And then for basal insulins, we had NPH for the longest time. And it was not very ideal because it did not last you all day. It only lasts 16 hours, as you can see here. And it even peaks on you where you don't want it to peak. So that is really a source of a lot of difficulty and management before the newer insulins have been out. So you have long-acting insulin in the form of glargine, detamir, and other equivalents to glargine. They last for 24 hours. And after that, we now have the ultra long-acting insulins that supposedly don't stack. And so we have insulin degludec. These are once-a-day insulins still. And then the thing is, how do we perfect your basal insulin where it is very steady and not variable and doesn't go up and down? So this is what we are kind of doing and discovering, and this is newer types of insulin. How do they do that? They change little bits and pieces of the molecule. They change some amino acids. They make the insulins bind better to your protein and help it circulate better. And so as you see here, the Tresiba is the one in lime, the insulin in lime green. They just measure a level, and as you can see, Tresiba taken every day gives you that amount all day long, where you had the previous insulin where you took the same dose every day, but then it got absorbed very variably throughout the day. So this is the source of a lot of research and a lot of drug discovery. And fresh off this was recently presented at the recent ADA meeting in June. We have insulin icodec. This is basal insulin that you inject once a week. So you don't have to inject insulin anymore every single day. We're trying to move into more stable insulins that can be injected once a week. And as you can see, when they compare it to the once daily insulin, once you get to steady state, you are even more stable. You don't have the up and down. So we are trying to change mindset slowly, in that you really don't need it so often, but we could manipulate the molecule where it can be very steady. But it's a hurdle because if you're used to injecting, say, 10 units of insulin every day, if you move to a weekly dose, then you have to inject 70 units, 10 times 7. So sometimes that amount is very hard to kind of get over, that you feel like, oh, I might die from hypoglycemia. But if you look at their clinical trials, it's actually very steady. And these are just graphics on how they work, and that they are transferred from under the skin to the bloodstream. And this is the subcutaneous area where the receptors are. And so as you can see, steady state, if you have an equal amount of insulin in the bloodstream and in the tissues, then you achieve this steady state, which is very stable. So another group of research that you have, I'm sure, heard of in TikTok or social media right now is there's another whole group of gut hormones that have been discovered that's been very helpful for diabetes and also weight loss. These are called the GLP-1 receptor agonists. So meaning they, when we eat, there are apparently 200 gut hormones that come out. And this is one of the 200 that have been shown to have so much use in the field of diabetes, because they don't only act on the blood sugars. They apparently we have so many receptors all over the body. And when I give you more GLP-1, then there's some satiety. You're not so hungry. It helps the kidneys pee out a little bit of sugar. It helps the fatty tissue kind of get rid of the fat and help with weight loss. It helps your pancreas secrete the appropriate amount of insulin. And it also helps the GI tract slow down a little bit so that your body has time to respond to all of this stimulus. So this is the science of GLP-1 receptor agonist therapy, and the most famous one is Ozempic. And so this has also really transformed our kind of science and the way we treat diabetics, in that when you compare it with insulin, let's say you're on pills and you're not under control. What do you do if I gave you insulin, and what happened if I gave you Ozempic? And so if I gave you insulin, then you can lower your A1C by this much. But if I gave you, and this is once a week injection, you're able to control your blood sugars even better. When I give you insulin every day, you gain 2 pounds. But if I gave you Ozempic, instead of gaining weight, you lost weight. So you're able to control your blood sugars better with weight loss. So this is the premise and why we are very keen on giving all our diabetics GLP-1 receptor agonist therapy. And then there's another drug class that has also been very useful, is we can utilize the kidneys to help you pee out sugar sooner. And there's another group of pills that you've heard, Jardiance, Farxiga in commercials. And so basically the basic principle is like this. Your kidneys actually can hold a sugar of up to 250. And it's only beyond 250 where your kidneys cannot stand it anymore. You're peeing out sugar. And so this is why people with high blood sugars are known to pee a lot, get really thirsty, because their kidneys can't hold it anymore and had to spill it. And so, but we've actually utilized that mechanism and created these medications. SGLT2 inhibitors lower the threshold. So instead of peeing at 250, you're peeing if your blood sugars are over 150. And so that helps you control blood sugars as well, and helps the sugar get lower. Because you're peeing calories, you are losing weight as well. And it's also good for heart failure because it is a diuretic, so it helps you pee out fluid and all kinds of things. So it has use and has been shown to reduce the risk of hospitalizations for heart failure. It also protects the kidneys because your kidneys don't have to hold up to 250. It can kind of unload at 150 of blood sugars. So really useful group of drugs. So as you can see here, the A1C, you're able to control your A1C with their 3 drugs that are mainly in this group. And they're effective at controlling your A1C. They're also effective at helping you lose weight, SGLT2 inhibitors. And so we use them a lot together. And here is my case. I've been asked to present a few cases. And so this is actually my main case of a 70-year-old male with type 2 diabetes. But what I want to tell you, as you can see here, so basically what I did was gave you a screenshot of his blood sugar control over a period of almost like 9 years, because that is how long it takes to kind of work with a patient to get them under control. And I could tell you in 2014, we had none of these medications, okay? We had no GLP-1 receptor agonists that were really good. We had no SGLT2 inhibitors. They were all like, they all came out later. And so this patient presented with just, he was just on insulin. So this screenshot got cut off, but he was on 130 units of insulin overall. And his blood sugar was out of control. The goal control is 6.5 and he was 10, and that's equal to around 280 average. And so what I did during that first visit was, the goal is, right, I need to remove the insulin slowly and add those medications that help you lose weight and control your blood sugars. So because you don't want to just keep increasing the insulin, which in fact makes you gain weight. So it's kind of, we were trapped before then. I couldn't help you but increase the insulin that made you gain weight, and then all of a sudden you need more. So I thought that was really very counterintuitive until we had these medications. So quickly, I added the SGLT2 and I added a GLP-1 at that time. I was able to reduce insulin from 130 to half, 60 units of just the base insulin. And as you can see, his A1C dropped to 7.9. And then Victoza was a daily injection. We were able to give him an equivalent to Ozempic. It was Trulicity once a week, because that was what we had at that time it first came out. As you can see, blood sugars were slowly becoming under control, and we were slowly able to reduce the amount of insulin. Now he is down from 60 to 50 units. And then it took another year for him to lose more weight, because he was on 2 medications that helped him lose weight. He was able to get his control down to 6.3. He was basically under control at that time. And so we were able to continue to have the amount of insulin. So instead of 50 units of basal insulin, he was able to go down to 26 units. And then after some more time, another year passed by, and we Ozempic was there finally, and I was able to get him up to 1 milligram of Ozempic, and he was able to finally come off insulin. So meaning, whereas 6 years ago, he was on 130 units of insulin, and with these medications, he was able to come off insulin completely. And at that time, blood sugars were decently under control, and finally, it was in 2022 and through 2023 where you got everything that he wanted. You had good control of his blood sugars, and he was on a pill plus a once-a-week injection. And this is his weight. So in 2013, he weighed 269 pounds while on this much insulin and out of control. And over time, as you can see, 269 became 261. And the less insulin you gave him, the more weight he lost. 245, and then 233, and now this year he weighs 213 pounds. So this is the beauty of our new diabetes medications now. And this is why I love endocrinology, especially at this day and age, because it has become so relevant. And so important work that we are doing is kind of unlearning old habits and trying to fit in new science that we have learned like 2 decades ago and applying it now for the betterment of these patients, that you are able to get them under control and have them lose weight. And this is why we feel strongly, right? We have a very big supply deficit with Ozempic and these new medications. This is why we feel, can you see here why it's so important for these diabetics to be continued on these medications and not be affected by supply constraints. So this is why I also wanted to present that GLP-1 receptor agonist therapy like Ozempic has been shown in cardiovascular trials that they are able to lower the risk of a diabetic's, they were able to lower a diabetic's risk of a heart attack, stroke, and sudden death from cardiac causes. And so why is because you are also enabling this patient to lose weight, and therefore weight is everything in diabetes, because when you lose weight, you lose insulin resistance, you lose out of control blood pressure, you lose out of control lipid. So with weight loss, you control blood pressure, you control blood sugar, you control lipids that ultimately reduce your risk of a heart attack and stroke. Okay, so I stop right here. We have around 8-10 minutes. So I want to kind of move forward to another topic, which is thyroid. So with thyroid, so new advances in the thyroid science is that endocrinologists now, we have been able to kind of bring these machines to the office and look at the thyroid gland ourselves using ultrasound machines. And this is what the thyroid looks like. This is the windpipe, and this is the thyroid draped over the windpipe. So when a patient's lying down like that. And so we have thyroid ultrasound machines in the office, and this is a thyroid nodule, very clear. And we use these machines to guide us into doing fine needle biopsies in the office. So it used to be when I trained, thyroid nodules did not get biopsied until you could feel them between your hands. And by that time, they're already 2.5 to 3 centimeters large and possibly cancer. And so now we have brought these technologies into the office. And okay, now we are taking it a step further into what if you have a large goiter? A goiter is medical term for enlarged thyroid gland. So what if you have a large nodule? Is your only recourse surgery? And now the answer is no, because we are now entering the field of interventional thyroid care. And so we have interventional thyroidologists, which is also, we are adapting this in our clinic. Meaning instead of just inserting a needle, you're inserting a heat probe. We call it thermal ablation. So at the tip of this probe delivers heat, whether, so this is radio frequency, you know, because of the frequency, it changes the molecules and delivers heat at the tip. And so you're able to shrink these nodules before RFA treatment, and after RFA treatment, you can see significant. And so when you have these patients avoid surgery, then there's no way that surgery can just remove the nodule. The surgery, you have to decide whether to remove one side or the other side or all of it. And so if you just wanted to remove that nodule, we can shrink it. And so therefore it preserves thyroid function. So then you don't have to be dependent on thyroid hormone therapy. And then we move on, adrenal and pituitary disorders. You know, Cushing Syndrome is still a thing, although rare. These are pictures lifted off public space. And if we find Cushing's means too much secretion of cortisol by your adrenal gland or your pituitary gland. We have acromegaly, which you hope to see 1 or 2 in your career. Acromegaly is very hard to diagnose because it takes a long time. As you can see, this was patient in 1998. This was patient before she was diagnosed. Subtle changes like over time. And so these are typically caused by pituitary tumors. We deal as endocrinologists with disorders of sex hormones. So we have many gels and creams and pellets and injections of testosterone or estrogen. And so the patients also come to us with symptoms of low testosterone or low estrogen and menopause, and we guide them into what's the indication, what is the safety, and how do you want to replace these hormones. So we treat them not as a judgment. We give you a diagnosis, we measure it properly. If it's indicated, you're entitled to it. And so that is our charge as endocrinologists, is to make sure that those who need it and are entitled to it do get it without judgment. And so that I feel strongly that, you know, if it's low, there's an indication. And this is estrogen. We have a patch, we have a cream, we have spray, we have gels. I also deal with transgender medicine, male to female, female to male. So again, without judgment. And as this is a diagnosis that has a DSM-4, and once a patient is evaluated by psychiatry and deemed to have gender dysphoria, and we have guidelines that we follow to a letter, but if you meet those guidelines, you are entitled to treatment. And so we have guidelines, meaning we do have a population that is affected by gender dysphoria. And so I'm an adult endocrinologist, so I do not deal with puberty. And we treat to target to a hormone level that matches your gender identity. And we discuss a lot of things, meaning, are you sure? And what's our goal for you? And how do we preserve your fertility in case that is a goal in the future? So next, I have a few minutes, and I want to I was found because of social media, and I am a doctor who's already 25 years into medicine. This is supposed to be not my realm. And so I started my social media presence in 2019 because hormone science is full of misinformation, correct? And you are living under a rock if you don't agree that there are so many self-professed hormone experts out there in the universe. Sometimes they're misinformed and they lack training. And they are most likely selling you supplements. So we all have to be careful. And this is why I decided to get into social media, is because if I'm not participating in the conversation, I cannot complain. And so I want to kind of get the information out there that is evidence-based. And so that's one of the reasons why. And there's no use, I think there's no use fighting it, because when you have a patient in the room, there are three of you in the room. There's you, the patient, and there's the internet. So there's just no way around it, meaning we can't complain if we don't contribute to it. And so there's been this debate: do we participate, or do we use it with restraint, or should we not be in there? And so, as you can see, there are people who have really taken it too far, like Dr. Oz, who have benefited or have had a lot of conflict of interest. And kind of changed over time. And so do we need to be restrained? Is it our personal time? There was this big thing in social media in 2020 where, there was a journal that was published in the Journal of Vascular Surgery in 2020 that stated that there's a prevalence or increased prevalence of unprofessional people in medicine. The writer or whoever wrote this article kind of stalked the accounts of all the residents where he was at, and then kind of judged that, yes, all of them were unprofessional because they had made some statements, or they wore bikinis in their personal time, or had a drink in hand. Therefore, they were judged all unprofessional. Never mind that this lady said that, yeah, she was in the bikini, but she was here trying to save this patient. And so, is that unprofessional? So there is that kind of push and pull. And so anyway, later on, this article got retracted, and this gentleman apologized. And so this is me. And if you can see, this is my content. It's really not, it is not exciting, but evidence-based data is very slow. It's really very hard to get to. The statements have to be so careful. So we are trying your best. So I think that's where I should end. And that is around 41 minutes. So I have a few more slides, and I do clinical research as well in my practice. So that is another charge. So the modern doctor has to be a good clinician, compassionate, up to date in their science, up to date in their technology. I think the modern doctor has to participate in some social media education. Modern doctor has to also engage in the science by participating in clinical research and also in the teaching of students. So thank you for having me. I'm open to questions.
Well, I just want to say that personally, I'm very interested in endocrinology. Just weirdly, when I studied for the MCAT, there was a lot of endocrinology in it. So I recognize some of the things, the pathways especially, that you mentioned. And we actually had one other student mention in the chat that they're starting to love endocrinology just from this session too. So we really do appreciate you for getting this presentation together, Dr. Tan.
Thank you.
In terms of questions, I wanted to just start off with something that you touched on briefly in your presentation. You mentioned that you specifically treat adult patients. You're an adult endocrinologist. And I'm not sure if this is something that many students realize, but is the reason that is the case is that because you went through internal medicine residency where you only care for adults?
Yes. So endocrinology is a subspecialty of internal medicine, like cardiology, nephrology. They're all, you have to be internal medicine first. So there is such a thing as a pediatric endocrinologist, where you go through pediatric residency and then go to the pediatric subspecialty. And so I think if you're a pediatric endocrinologist, obviously there's a lot of care in the science around puberty and bone growth, aging, and there are a lot of developmental and congenital disorders of endocrinology. I wanted to bypass all that. So I said, like, okay, let's just finish your development and kind of grow and stop, and I'll take care of the rest.
Yeah, I hear how a lot of physicians say that pediatrics is just complicated. It's a whole nother area of medicine on its own. That's why we have a whole different residency and route to it.
Yes.
But another thing that you mentioned was, and you had a case on this, Cushing syndrome. So you mentioned that it could either root from the adrenal gland or the pituitary gland, right? How do you go about pinpointing which one it is? And does treatment look the same depending on if it's adrenal versus pituitary?
No. Okay. So every time you have an endocrine condition, okay, you have to establish, hey, is the cortisol too much? And so you have to prove that, yes, the cortisol is being secreted too much into the system. So what we do is you measure cortisol through blood, you measure cortisol through the urine test. We call it a 24-hour urine collection. You also measure cortisol from the saliva that is collected at 12 midnight. The cortisol is very hard to diagnose, and you cannot just say, collect it now, because the most important thing about cortisol is circadian rhythm. There is a gush of cortisol in the morning because that is our wake-up hormone, and as the day goes, it slowly goes down. At midnight, your cortisol is supposed to be close to zero. So therefore, that's why we collect the midnight salivary cortisol, is that if you have higher than zero or higher than point something at that time, then you know something is wrong. You have lost that circadian rhythm. So there are two sources of cortisol oversecretion. There's actually more than two, but the basic is you can have adrenal nodule or adrenal growth, and then it is just by itself decided to produce too much cortisol. You could also have a pituitary tumor producing that thermostat, that ACTH. So the ACTH you could also have another nodule, but it's in your pituitary, and that pituitary nodule happens to be ACTH producing. So that is the drama in endocrinology. Once you establish that something is being overproduced or underproduced, then the next step is to determine where is the problem. Was the problem up in the brain where the stimulatory hormones are, or is the problem in the end organ? So who decided to do what? So it's either primary is from the adrenal, secondary is from the pituitary. And to complicate matters, there are some, like cancer tumors, it could be in the lung that produces ACTH. So sometimes that ACTH doesn't come from just the pituitary, it can come from a cancer elsewhere. So these are the nuances that we have to study.
Like you said, it's almost like the heart of the body. So there's going to be a lot of complexity to it, but makes it very interesting, doesn't it?
Yes, it is very interesting. It is not really that complicated. You just have to follow the strings and understand that basic principle. Mm-hmm. And so when you have, for example, if you have a hormone, too much or too little, after that, you just need to find the source. And how do you know it's not the pituitary? If it was not the pituitary's fault, then the pituitary hormones will be low. Because, hey, I'm feeling too much, I don't need to stimulate you anymore. So therefore, if it wasn't my fault and I'm seeing too much, then I ought to drop, and that's normal. So, but if it was my fault, if the pituitary decided to overproduce, then The TSH, ACTH, FSH, LH are all high because it came from them. So it's really, once you just get to know the feedback system and start to understand, it's really not very difficult. I think people and medical students, I've also, a lot of my classmates got deterred from endocrinology because they just couldn't understand, it got too confusing. But there's only two ways. If it's high here, it should be low there. So you just need to understand that basic etiology, and it's not too hard. It's actually pretty exciting because, I love endocrinology. Another interesting thing is, seems like you look around the room and nobody's understanding it. And even when you're out in practice, all the doctors around you don't seem to understand what's going on. But you carry the answer, and it's so gratifying.
That's the beauty of being a specialist. And speaking of that, actually, our next question is just about that. I think you touched on osteoporosis, right? I mean,
no.
What I understand, that would connect with dermatology, right?
So yes, that is osteoporosis's problem, that condition. And we have talked about that. Whose disease is osteoporosis? Is that the orthopedist problem? Is that the rheumatologist problem? Is that the endocrinologist problem? And so that's why we feel sometimes that osteoporosis research is lagging and the awareness is lagging. But endocrinologists like to think that, yeah, we have a little hand in it because calcium metabolism, calcium is controlled by a hormone, parathyroid. And so that is one of the conditions that had to be ruled out. So therefore, we admit to it, like osteoporosis is probably a little bit also ours, along with a rheumatologist.
In terms of training paths, to kind of go off of what we mentioned about going either pediatrics residency or internal medicine residency, I know that there is a subspecialty for reproductive endocrinology, right?
Yes.
Are there any other subspecialties? Go ahead.
That's it. I think reproductive endocrinology is also kind of a little bit more special. That is through obstetrics, OB/GYNs.
Okay, and that's good to know because it adds another layer of
layer. I know.
Yeah.
The reason why is that because there are surgical procedures in fertility, right? That I cannot use my ultrasound and go into that area.
Mm-hmm. And then another thing is kind of on that same line of thought. I'm not sure if you do care for PCOS.
We also do. Yeah, it's just too many conditions to mention. So PCOS, and it's also in my, it's in my slide. In fact, here, what is the underlying cause of PCOS is actually insulin resistance. So it's seemingly, not related, but all of the cells in our body need sugar to work because that is the basic, working mechanism. That's the source of energy. And so your ovarian cells need sugar to work. And when there is underlying insulin resistance, it cannot get to its sugar source quick enough. So what does insulin resistance mean? So every cell needs insulin to stick to it, to open up the cell to get the sugar in. Resistance means that instead of needing 1 molecule of insulin per cell, you need 2, 3, 4. You're not a diabetic, not yet, because if your pancreas is strong, it can make 4 or 5 molecules per cell to overcome resistance. But the ovaries are extra sensitive. If they cannot get to their sugar source quick enough because of that resistance, and it takes a little time, they revert to pathways that produce their energy by alternative means, and those pathways produce byproducts that send mixed signals to your pituitary so that your ovulation is disorganized. And then it also, as a byproduct, makes a woman secrete more testosterone. So this is why PCOS is a convoluted, mishmash of conditions that is basically infertility, irregular periods, and hyperandrogenism, meaning hair, acne, hair loss. But when you look at the underlying mechanism, which is insulin resistance, this is not good. You are straining your pancreas, and that leads to diabetes in the future. So I actually encourage women who feel that they have PCOS, and I tell them, this is good because a man will have no such signal because a man doesn't get a period. Nothing alerts a man that he is insulin resistant until you get to 40, 50 years old, you get the heart attack. But women get it much earlier, reproductive age. So your periods are irregular. So that gets you to go to the doctor and realize you have it, realize you have to keep your weight down, realize you have to control your, keep a watch on your blood sugars and your cholesterol. And so it's a little bit of silver lining, but yes, it's difficult and it affects a lot of women.
Wow, that point is eye-opening. I never ever considered that. Another thing just about PCOS too is, as a clinician, just in your everyday practice, how much do you see genetics versus lifestyle choices contribute to PCOS?
So I feel, you know, so that question segues into, for example, obesity. And so that's a whole nother topic. I might have to come back here, another session, talk about obesity. So, you know, recent science suggests that genetics, for example, obesity and insulin resistance. Insulin resistance is polygenic, meaning you cannot blame one, you know, like it's not Mendelian. So it's polygenic, meaning there's so many genes controlling the way you manage your insulin. And obesity is genetic, and it's been quoted 40 to 70%. And so there's just too many hormones that control your appetite. So when you're hungry, is that really willpower? Or is that is that willpower, or is that hunger hormone? There are about maybe 10 hormones that have been discovered. You know, some increase appetite, some reduce food intake, leptin, ghrelin, adiponectin. There's so many. And so the more we discover, the more we should judge less. And that, yes, of course, there's a component. That's why we're adults, and I don't like to treat kids, because kids, you can't kind of, you need to, but you can't really hold them to account. But adults, you can hold them into account, right? And so, but I would also say that there are so many adults who are really responsible with their health and get nowhere. And so that's where I'm coming from, is perhaps I or our generation wants to train endocrinologists and metabolism cardiologists, doctors who are less judgmental towards their patients, and don't tell their patients that you can just eat less. But if I told you it was 70% genetic, meaning, yes, I've tried that and I can't lose weight, and I've seen that day to day with patients. And so perhaps we can get to the science, and this is why we feel that it's not really a cop-out if we think that it's polygenic.
That is a very good point. And then one more question to wrap up today's session is, just personally, did you consider any other subspecialties or specialties for residency as you were making your choices?
Briefly thought about surgery, but when I realized that surgical residents needed to wake up at 3 o'clock to go to the hospital, prepare charts, and do their pre-ops, I like my sleep, so cut that. Briefly, OB, but when I got into those rotations, kind of didn't look good, so that cut it out. Also thought about critical care, but endocrinologists, I guess, are people who value their sleep and their own circadian and quality of life. So this is why I wanted to be an endocrinologist since I was a second year in medical school.
Well, endocrinology is looking very interesting for me, and I'm sure a lot of students have caught on an interest. The points that you've raised as we ask questions, that they've really connected the dots in some areas that I never did before. So again, thank you, Dr. Tan. Let's hear some thank yous in the chat for Dr. Tan too, for getting this presentation together, for taking some time to answer our questions. I do have one last reminder for y'all who are listening in. We do have a quiz, and if y'all would like to earn credit for your attendance today, that quiz is posted in the chat box. It's a Google form, 10 questions, and if you have 6 or more correct, you will pass. It will be due next Wednesday, August 9th at 11:59 p.m. Central Standard Time. If you happen to have any issues with receiving the certificate, it should be sent to the email address that you list on your quiz form, then feel free to email us. Again, our email is community@hearts4health.org. For our next shouting session, we're going to be joined by, I believe it's Dr. Krishon. He's, if y'all were with us earlier this week, he's another medical director at an Encompass Health Rehabilitation Hospital, specializing in physical medicine and rehabilitation. So we'll have two directors, one earlier this Monday and Dr. Krishon next Thursday. We will not have a session on Monday, just keep that in mind, but it's going to be at our usual time, 7 p.m. Central on Thursday, August 10th. With that said, though, if y'all want to stay tuned with more shouting sessions, then we have our Instagram page. We also have our listserv. Dr. Tan also shared her screen with her Instagram page. And like you said, she has evidence-based posts. So if you happen to catch an interest from endocrinology or about endocrinology today, definitely give her a follow. Some informative content on there. But outside of that, that will wrap up today's session. Again, thank you so much, Dr. Tan, for taking time to join us today.
Thank you so much for having me. Had fun.